Right. Well, good morning again, and thank you everyone for joining. My name is Casey. I work for the EMS for Children Innovation and Improvement Center, and I would like to welcome you all to our first Pediatric Readiness Quality Improvement Community of Practice session. We are excited to welcome you all, whether you are a returning participant from the PRQC or if you're just joining us for the first time as an NPRQI user. We are looking forward to catching up with you all and helping to create a network of ED professionals from across the country who are passionate about improving pediatric emergency care. We hope that this is a space to come together and share your experiences, network with your peers, and provide one another with support as you navigate your quality improvement efforts. Joining us today, we have Eleni Belordis, Drs. Kate Remick, Corrie Chumpitazi, and Emily Sterrett, and we are here to support you and your teams with your QI efforts. Before we get started with today's session, we would like to acknowledge that the EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIC must adhere to executive orders and related federal guidance. Currently, the EIC funded staff are unable to engage in activities or discussions on topics such as DEI that are limited by executive orders. We appreciate your understanding and ask that all meeting attendees to refrain from discussing any topics of concern defined within these executive orders. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. As a reminder, portions of today's session are being recorded and will be posted to the EIC website along with today's presentation. You can explore our newly published PRQC Community of Practice webpage. The QR code will direct you to that new page. You can then navigate to the session's recording, where you'll be able to see session details and information. You can also navigate to our resources tab, which will provide you resources to you and your team on your QI efforts. To get us started today, I will hand things over to Dr. Kate Remick, the co-director of the National Pediatric Readiness Project, to share with us an overview of the pediatric readiness and why we focus on quality improvement.
Thanks so much, Casey. Good morning, good afternoon, depending on where you're joining us from. It's great to see you all on the call today. The National Pediatric Readiness Project, as many of you know, is an effort of many decades now that was really solidified as the National Peds Ready Project about 13 years ago. And this visual really describes kind of the full scope of what the National Pediatric Readiness Project is about, with the primary goal of ensuring that all children have access to high-quality emergency care, regardless of what community or region of the country they live in. There are 5 real pillars to the National Pediatric Readiness Project. The first of which is the National Pediatric Readiness Project Assessment, which I suspect that nearly all of you know about because you made it to us today on the Peds Ready Quality Collaborative. But this assessment is based on the joint guidelines co-published by the American Academy of Pediatrics, the American College of Emergency Physicians, the Emergency Nurses Association, and most recently and upcoming in 2026, the American College of Surgeons Committee on Trauma. And this set of guidelines really describes the infrastructure or the structural components that every ED should have in place in order to meet the emergent needs of acutely ill or injured children who present to the emergency department. Typically, this is launched through the EMS for Children data portal, which you all can find at pedsready.org. We have a few big pushes every few years, but also open access to the portal on a regular basis for ongoing quality improvement. Accompanying that, or in conjunction, is the toolkit and checklist, which lives on the EMS for Children Innovation Improvement Center website. There are a wealth of resources, templates, guidelines, educational materials, and support to help any and all emergency departments in becoming pediatric ready. We host also a number of quality improvement collaboratives, the Peds Ready Quality Collaborative being one of the core QI collaboratives that we try to offer on a regular basis, and really the foundation for what is the Peds Ready quality community of practice that we're launching today. During these collaboratives, our goal is to really help support you to implement pediatric readiness in your ED, either through adapting to the guidelines and the structures that are within, or implementing your own QI process improvement effort. The National PEDS Ready Quality Initiative is a quality improvement platform. It's a data system, secure, confidential, that is used to help support those quality improvement efforts. It's a web-based and therefore easily accessible platform that allows EDs to engage with quality improvement and actually visualize their performance in near real time and drive those improvements over time. And then lastly, and ultimately, we are trying to support EDs to become recognized as pediatric ready EDs. This is akin to stroke and STEMI and trauma centers. But now the majority of states now have facility recognition programs where if you have done this work as an emergency department leader or champion, then this becomes the opportunity for you to really showcase that great work and demonstrate to your hospital leaders and hospital administrators that you all are committed to children. So next slide, please. That is really the overview of the National PEDS Ready project, and it's really grounded in quality improvement. And as nearly all of you know, I'm sure, which again is why you're here, is that our healthcare system has very much embraced quality improvement. It really started diving into quality in the late 90s, early 2000s, when the Two Eras Human Report came out and really showcased all of the failings of our healthcare system broadly. Children, though, in particular, are at much higher risk. And what we know now is that if we engage in quality improvement, that can lead to a 25-point adjusted increase in your weighted pediatric readiness score. That means that if you took away the points associated with quality improvement, that you would see a 25-point increase from all other components of pediatric readiness, leading to potential significant increases in survival. STEMI, stroke, and trauma centers all require quality improvement as a core component of their program and for designation. And really what we're trying to do here is to drive improvement in patient outcomes by adhering to foundational critical processes of care that we know from the evidence lead to improved survival or patient-centered outcomes. So this is why we use quality. We know it means that children are safer if we practice quality improvement because we're following our processes and adhering to them. And we also know that these lead to the best possible outcomes for patients. Next slide, please. So the National PEDS Ready Quality Initiative, if you have not yet joined this data system, this data platform, we encourage you to do so. Your emergency department and or hospital can go in and start the registration process. It is, as I said, a web-based quality improvement platform. It is completely free, and it provides your emergency department with access to visualized data, visualized performance over time. So it is 100% confidential. It has federal regulations for patient safety organization requirements. It's very simplistic in terms of being able to navigate the platform. When you enter into this platform, you document a pediatric encounter with very specific, simple variables that are then entered in, and they can be transformed into measures that then reflect your performance and allow you to drive those improvements forward. The really nice thing about the National PEDS Ready Quality Initiative is that it allows EDs to not just see their performance and drive those improvements over time, but also to begin to benchmark their performance with similar EDs. So if you're a critical access hospital, then you can compare your performance with other critical access hospitals. If you're a level 1 trauma center, then you can compare your performance with other trauma centers. And this is really a core set of pediatric specific quality measures. There are a total of 28 measures that are integrated into NPRQI across 7 different clinical areas of interest for the most common reasons why children seek emergency care. And it is a really terrific starting point to begin your quality improvement initiatives. So with that, I think I'll turn it back to Casey to take us to the next step. Thank you.
Thank you, Kate, for that overview. We'll pause briefly if there are any questions for Dr. Remick. Help address those now.
And you'll see in the chat the link to join in PRQI if you have not yet. And if you have any questions, you'll find all sorts of contact information, resources there regarding the registration process. So we can help assist with that.
Thank you. All right, so before we move on to our next section, we did want to take a minute as we are building our community. We wanted to get to know you all better. So if you can please take a minute and put in the chat your name, what hospital you're joining us from, what your role is within that emergency department. And if you happen to be your pediatric emergency care coordinator or the PEC within your ED, please include that as well. We look forward to learning a bit more about you all, having additional opportunities to get to know you over the coming months. Thank you for getting us started and sharing that in the chat. Some familiar names, so thank you for joining us. And a number of PECs. It's great to see. Well, we're happy you found your way here this morning. Thank you. And if you have not gotten a chance, go ahead and just put that in the chat. We'll go ahead and move on. So we are pleased to have Drs. Corrie Chumpitazi and Emily Sterrett with us today. They are joining us from Duke University. I'm here to share some information on pediatric pain assessment. Then we will open the floor to questions and discussions on the topic. As a reminder, if your site has been working to improve pediatric pain assessment, we would love to hear an update, a brief update from you on how things are going, such as what interventions you've implemented or tried, and maybe what you hope to accomplish next. So with that, I will hand it over to, I think, Dr. Sterrett.
Good morning or afternoon, depending on where you are. Again, I'm Emily Sterrett, and I'm a pediatric emergency medicine physician, and joined today by Corrie Chumpitazi, who is my boss and fearless leader in this work. I am also one of the subject matter experts for pediatric pain management in this collaborative. And so today we're going to talk about strategies to enhance pain assessment in emergency care and pediatric emergency care, and really focus on how do we optimize our pain assessment quality measure and ensure that all of our patients are having effective implementation of their pain scores into their medical record, and how we're doing this in all kinds of settings, including some resource-limited emergency departments, which you all may be representing. We know that pain assessment is a fundamental part of pediatric emergency care, but it is inconsistently documented and under-addressed. And so today we're going to explore some best practices, share data, and hopefully discuss some practical solutions that you can implement. We'll start by looking at how pain is assessed and where we stand today. The slide in front of you is our national performance as of just a couple of weeks ago when this slide was updated. And I took a moment as I was preparing for today to look back at where we were around this time last year. And we are getting better. So national average last year, we reported at 78.4. So are making gains. I know it seems small, but those are actually a whole lot of patients when you think of the breadth of the national coverage involved in this collaborative. And when we look at where opportunities exist and where some of our improvements today have come from, they've really come from our medium to high programs. So sites that are seeing, 2,000 to 10,000 patients every year. And we're seeing those numbers get better. I think for both the numbers in front of you, our pediatric pain quality measure scores have improved over 3% in those two groups. So super excited about that. But you can see we still have a gap and we still have some improvement to make. If only around 80% of our patients are having their pain assessed while in the emergency department. So addressing and recognizing these gaps is kind of the first part and the crucial part for improving our outcomes and where we want to go with our pediatric department readiness. And so a major barrier to really effective pain management is not using or inconsistent use of validated pain scores or validated pain assessment tools, which is what we're going to talk about on the next slide. So here we have shown 3 different examples of validated pain scales that are really essential to accurately assessing and managing pain. On this slide, we see the FLAC score, FLAC being an acronym for Face, Legs, Activity, Cry, Consolability, and is really used by caregivers and providers for nonverbal and pre-verbal children. So those are for our youngest among us. And then you see the FACES score. So we have a revised FACES score, which is good for younger or nonverbal children who may be able to recognize kind of the image or the facial expression on that scale, or the numerical or verbal score, which can be used in our older children and adults who can really kind of interact with the pain scale as you classically would have. Tell me what your pain number is from 0 to 10. Research has consistently shown that using standardized pain scales like these improves our ability to recognize pain. And when we're recognizing it, we're better at managing it. So how do we make sure that these tools are used consistently and appropriately in really, really busy emergency department settings, and in some settings where children are among the minority of the patients that you see? Certainly during our discussion Q&A session, we'd love to hear if any of you have encountered difficulty implementing any of these tools, and we can help kind of navigate some of those strategies for you. Let's talk on the next slide about some of the strategies that we can think about when we want to improve pain assessment. Kind of in classical quality improvement methodology, we start with the foundational work. We start with the training, the follow-ups and feedback, having dialogue with the folks in your setting, learning from them what is going well, what's not going well, and having kind of that one-to-one conversation with your staff is a great place to start. I'm going to go to the next slide. When we go beyond kind of one-on-one conversations and dialogue, or maybe some of your training sessions, we think through how can we incorporate visual cues into your training. Visual cues can be really powerful reminders to kind of what you're trying to achieve and how you're going to continue to engage your frontline audience. Another key piece of this is figuring out how do we build some of these visual cues into spaces and areas that are going to keep the attention of your staff. So perhaps it's putting flyers in break rooms or posters in the triage area where we're expecting triage vital signs to happen, and we want those initial kind of pain assessments happening. And then how do we reach our staff kind of on a day-to-day, daily basis? Do you have huddles? Do you have shift change or standard ways that you're doing sign off or handover? Can you incorporate education and visual cues into that standard work of your department so that pain and this implementation of your pain assessment tools are kind of at the forefront of everyone's mind? And then next, or part of the last part of implementation methodology is really how do you have a hard stop? How do you break the work or break the continuing of the work until you've done the critical piece of the work? So some folks have had success implementing hard stops for pain reassessment in their electronic medical record or electronic health record. What this might look like is if you are in triage and you are documenting a set of vitals, you can't go on to the next step of triage without putting in a pain assessment. And then similarly, if you have cues or signals built into your medical record that are telling you when you're overdue or when a vitals reassessment is upcoming, ensuring that pain assessment is linked to that vital reassessment. And there's really a stop that says, okay, you took the temperature, the heart rate, the blood pressure. Did you check the pain? And making that a part of the workflow. I show an example here. This is actually a snip from our ED track board here at Duke, where we have a column for pain reassessment. And that is on the track board. It's visible for everyone, and you can see the time stamps of it's an elapsed time from the last pain assessment when you have a green check and the pain was good, or you have a yellow or a red, meaning that you're overdue for your assessment, or perhaps that patient is in a lot of pain and we need to address that. I'm going to go on to the next slide. We've got some other resources that you may find impactful and kind of right at your fingertips. I have to remember to search for these, and I just search peak EMS pain, and it's typically one of the first hits I get in Google. But our pediatric education and advocacy kits have been a part of the EMSC improvement collaboratives. Under the pain management section, you have links to a lot of really helpful podcasts, articles, some infographics and videos, which may be helpful for you as a leader in this space, but may also be impactful to share with your team or to incorporate as a part of your education. There are also standard documents. So what you see on the right-hand side of your screen is an evidence-based pain treatment plan. And this may be really helpful if you're at a site or a center that doesn't take care of children as frequently, and you need some reminders for what are doses and appropriate doses of medications for the degree of pain and the weight or size of my patient. I will sometimes even use this tool as a teaching aid when I have a trainee or a learner who's working with me. This is a great kind of paper tool that I can print and sit down with a learner, and we can kind of walk through it together and talk about the different medications, how we think about medication dosing, and kind of cautions or contraindications. And then there's also a really nice section at the bottom that talks about how to counsel caregivers about the medications we're using and the importance of treating pediatric pain. Lastly, there is a podcast series, which if you're a podcast listener is another great way to kind of consume this information and think about what pieces of pain management and pain management strategies you want to bring back to your emergency department. Go to the next slide. That might be it. And so now we'll open up the call and conversation for any questions from the audience or things that folks have questions about or want to talk about their strategies.
Feel free to unmute or put them in the chat. And while we're doing that, Casey, maybe we can just go ahead and post which pain scores does your unit use? So we've got a little poll coming up just to see that while we're thinking about our questions.
This is Tara Davenport.
Hi,
Hi. So I don't see any of these that are listed for neonatal. So I was wondering who uses a NIPS scale for neonatal. Is it already built into your electronic medical record? And then if you're using NIPS, are you also using sucrose as a potential pain medication for your babies?
Great questions. So yes, so NIPS is a very widely used neonatal pain assessment tool, or NPAS, as I see in the chart in the chat. Thank you, Gabrielle. And then I think you get to the really important question, because if we assess pain, that's our first step, right? We got to know where that pain is to begin, but then what do we do about it? And how do we treat pain? And what level do we treat pain, and how do we know that we're effectively treating pain? And so thinking about then that management and reassessment are two extremely key points. And so I think you're getting some questions in the chat, but I think that's exactly what this collaborative does, right? So the first step is knowing where you are and what is your data on that pain assessment, but then how do we get to that treatment and improvement in that quality care? Does folks have examples of where they build in NIPS or NPAS into your electronic medical records systems? Yeah, and it's in the process too, Tara. Yep.
We have NIPS built in, but they're in the process of also adding NPAS so that you've got two options.
Yeah, fantastic. And maybe Dr. Remick too can talk to some of the work we're doing centrally within all of this work, is then working with some of the major vendors of the different electronic medical records, and how can we kind of establish centralized pathways so that each institution and hospital doesn't have to recreate its own wheel in building these in, that we can work with some of those to try to encourage them to have a standardized template for folks to use.
One of
Yeah,
our
for
other things was using the correct pediatric pain tool, because you have a lot that just click on the first thing that comes up, and then you're using FLAC for a 6-year-old that's verbal of normal mentation, and it's not evidence-based for those. And being able to we have them posted everywhere with all three put together, of which one would you use at which time. We teach it during our EMPC classes, but it still seems that we're clicking on the wrong one at times, or you're using a 2-year-old and giving them a numeric or a FACES scale for those, and it's really not evidence-based for those. So those are some issues that we have when it comes to assessing and documenting appropriately pain.
Really great points. Is how do you get to how your data comes out, right? So if they're using FLAC on all teenagers, there is a FLAC revised for some of our kids and youth with special healthcare needs, but overall, do you just try to filter out, how do you look at those scores and make sure that the data is clean, and that it's meaningful, and that you can then work on those next steps. So yeah, really great points, Tara.
And that may be an opportunity, if you have the luxury of working with your informatics and your EMR builder folks, where they could help you populate in the EMR the correct scale based on the patient's reported age. So that kind of takes some of that guesswork out and kind of forces the function of what scale to use for what age.
This is Cassie over at Huntington Hospital in Pasadena. Our EMR does do that. It says specifically, like, well, you kind of have to hover over it. So sometimes they'll still try and chart the wrong thing for the wrong age. But like, for example, if they're under 8, it won't let them put in a number for verbal. So then they have to hover over and see that they'd have to use FACES for their 5-year-old. But my question was, I saw, it looks like you had EPIC as well when you showed your Duke score for the pain reassessment. For us, we do have a pain reassessment that comes up, but it's only after we give a medication that they have like an hour to reassess. Is yours just in general, like every hour or every how often? And then, or is it similar to where it's after a medication?
I believe the one that I showed you, and it's been through some updates, but the one that I showed you, it's also after a pain medication is administered. So you can see on that list there are lots of different patients, but not every patient has had a pain assessment or reassessment. There are some blanks there. So yes, so we even have opportunity there to kind of work on we're aiming for pain assessments for everyone. That would be a gap for us as well.
Yeah, and to build on that example too, at my last institution, we really wanted to look at how we could empower the nurses to do those reassessments. It related to medications as well, because we did okay then on our assessment, but the reassessment and then what we did with that was a problem. And so if a medication was given and that took some building, if Tylenol or Motrin was given for fever versus pain, you know, what were your criteria for that? Was it a temperature documented? Was it a pain, you know, was it within X amount of time of a pain score documented that wasn't at what level? But really trying to tease out which of those medications were used for pain and which were most likely given for pain. And so once you had those, then we had 30 minutes from an IV medication or 60 minutes from an oral medication. And so we really looked at those windows, and then we used the nursing handheld to devices to set alarms for those things. So if you had a pain medication given within 30 minutes, there would pain medication given IV, you'd have a 30-minute kind of alarm on your on the nurse's handheld device, the rover that we used to be able to see if that pain was reassessed, and then similarly for an hour from oral meds. So there's ways to try to build some of those things into the technology that your hospital uses, but that's sort of that next level. Yeah.
I'll just speak to, you know, the strategies. Obviously, there are a lot of strategies listed here, knowledge reinforcement tools and education sessions and shift huddles and things like that. But as has been stated, being able to modify the electronic medical record system is probably one of the most effective mechanisms in implementing new strategies and adherence to evidence-based practices, certainly for pain, but also for many other areas of focus. And so while it might take a long time, it can be one of the most effective mechanisms to really promote standardization of care. And the one piece to add on to that is that for those of you who work in high volume centers or children's hospitals, you know that most of the EMRs are well adapted to meet the needs of the pediatric patient, but in non-pediatric settings, that is certainly not the case. The point being that it is very much possible, and many of these strategies already exist within those EMR vendors' portfolio. And so it's a matter of asking the questions and pushing for those modifications to be made.
Really important points. Thanks, Kate. So this is sort of what we've been seeing, that FLAC in the pre-verbal children. Wong-Baker FACES is still a very highly one that.
Thank you, Laura.
Wong-Baker FACES anchors on a smile, and then has crying as their 10. So a lot of the times, like the pure pain research societies really like that FACES pain scale revised versus Wong-Baker. But I think, you know, whatever you use it. And then getting to those tools, where do you have your pain scale to prompt folks to use it? Do you have badge cards to use it? Do you have communication board in your rooms? I work in the emergency department setting, as many of you do, and so we, you know, have communication boards, and it has the pain scale pictures on the bottom of that. What kind of tools do you have to be able to easily utilize? And then how can you make documentation easy, the way Dr. Remick was discussing? What other thoughts do you all have in listening to this discussion? Or for those of you guys that participated in this collaborative, is anybody available to share? Let's look to see who we can poke.
I'll speak a little bit. This is Gabrielle or Gabby Smith from Long Beach Memorial. Just to some of the challenges of, we can push for EMR updates and EMR changes, but for like larger hospital systems such as mine in particular, where it should be relatively easy to say, hey, this is evidence-based. This is going to improve our adherence and our performance overall. However, the cost to change the entire system is sometimes the barrier, and so while the evidence-based performance is definitely a priority, it has to be balanced with the cost of change and resources involved in updating the entire system. So I had a similar challenge. Mine in particular has been a barrier we're not really at the topic of weights documented in our EMR for pediatric patients, but it's the same push that you're making for this pain alarm and pain hard stop for reassessments. So it's the same barrier, just a different topic, but it's really challenging being one person, being the voice for this in an entire organization. So how we mitigate that is another story, and I don't want to overwhelm the conversation, but that's really the crux of it. Is I can bring all this forward and they say, yes, I understand, however, and then I usually hit a barrier when it comes to financial. So that's some challenges in particular that I've had.
Sorry.
I was just going to say, my name's Heather. I'm from Permian Regional in Texas. We did the November collaborative, and we weren't assessing not even all of our pediatrics were being assessed when I did our QIs. So we have improved on that metric, and we were able to update our EMR to the R flags. So that's was a positive on that.
Awesome. And then where did you integrate? Were you able to integrate the RFLAC or what lessons did you have on that? Because I think there's probably several on the call that might be interested in learning how.
Yes, we had to update our policy. So we're a very small facility. So it wasn't just changing the policy for the ER, it was changing for everyone. So I had to reach out to all the directors and let them know, this is what's going to happen. Sorry. And I didn't get too much pushback. I think everybody was okay with it, and just general educating to the staff. And the informatics department was phenomenal to work with. They've been very great. They listen. They make all my visions come to life. So I feel very fortunate that they're cooperative with us after listening to some of these other hospitals and the issues they're having with their informatics.
Yeah, fantastic. And that's where I think too, we can continue to build out our toolkit of resources. And so as you have screenshots for the builds that you've done and the, some of those lessons learned, we can continue to look at collecting some of those things so that everybody doesn't have to recreate some of those ideas from scratch. Because I think a lot of folks have very similar optimizations. They're going to be different ways to get there depending on the system and the extent, but yeah, really great work.
This is Cassie over at Huntington again. I had shared that our EMR system does have kind of locked screens for the different pain scales. So we already had that implemented prior to PRQC. So one thing that was helpful for us is I started doing chart audits and then putting them, we have like little mailboxes and putting those in. But then I think the most helpful thing, which is very time consuming, but is trying to do real-time audits when I was on shift. So actually looking and being like, okay, there's a kid, and going over and being like, hey, you haven't documented a pain. Do you know what pain scale you need to document? Because sometimes I feel like, looking at it a month later, because that's when I would get, my IT would send me all of our admissions and transfers, and that's kind of the kids I was mostly looking at. But looking at it in real time, I feel like helped our numbers a lot, because then I could, educate in real time. So even though it was time consuming, I felt like that was probably the most effective intervention that we did.
Yeah, that's really important, real-time feedback, and it's hard to catch both shifts, and certainly our workforce has been turning over too, but that's how you do that, because you a lot of the times can make assumptions retrospectively, but having that opportunity to have that dialogue, I bet there's things, a lot of things you learned from asking that you were able to address those questions real time as well, and asking those questions.
This is Amanda Hardy from Methodist Richardson in Texas. I started putting in our data into the NPQR or NPRQI system. And that's actually, we've always known that pain assessment on adults, but definitely children has been an issue. But until we put that data in there and we really saw the numbers, that really helped. And then at that point, we started the chart audits as well. And like she was saying, we tried in real time our NCCs out of the ED. I'm a trauma coordinator, so I'm not always in the works of the ED, but our NCCs down there, our supervisors, they do the audits, and I give them feedback on all the data and everything that I input. The challenge that we have right now, we do not have a way to document pain assessment on a pediatric patient who is 6 months and under, even neonates. However, our NICU does. So it's there. We just have to, I'm working with our informatics team to get that incorporated for the entire system.
Fantastic work, and that's going to have such a huge repercussion for all of the patients in the setting. So that's really great work. Is that a problem that you knew before, or a gap you knew that was there before this project, or just more so clearly delineated throughout this project?
I did not know it was there before this project until I started really digging into pediatric pain. And then that's when I realized and thought, this is also a problem for trauma, because we have to document a pain injury or a pain assessment on any head injury that comes to the ED, no matter the age. And we do, I mean, what really exacerbated this was we had a 5-month-old that came in and fell out of the high chair and ended up with a skull fracture and a brain bleed. And I noticed that there wasn't any pain assessment charted. Well, that's because it wasn't offered in our EMR.
That's a really powerful case. Yeah. And so important, especially with trauma verification and necessary for documentation, like you said, as a trauma coordinator, and seeing that, you know, probably fix that hopefully for your system as well.
Yes, I'm working with all the PECs in our healthcare system for all our sister facilities. So that way we can come together on policy revampment, and it'll all be the same system wide. And then of course these EMR builds as well.
Yeah, fantastic. We have so many great PECs on this call too, with our pediatric emergency care coordinators. What other aspects of the stuff we're discussing today would be most helpful for you all, as far as able to help demonstrate or justify, or where have you seen the biggest growth opportunities through participation in this community of practice, on things that, you know, maybe we can help with centrally, or the things that you have done that have been making differences? Or any suggestions on translating the pain scores to then your pathway? So a lot of folks to changing policies on documentation. We've seen a lot of that always takes a little longer than you anticipate, but then translating that too into protocols and what are opportunities or things where you've seen successes in the work you've been doing with this.
Like Gabby shared in the chat that she's appreciated the ability to benchmark within PRQI.
That is fantastic. And that was something I learned looking at my previously institution's data, as they said, you know, we're 90% compliant with our pain assessment. And I'm like, there's not a chance we're 90%. And so actually being able to do that data and do some of that real-time assessment, we were more like 30% across the entire system. And so how do we really then use that data to guide improvement, and then be able to convey those success stories to the leadership to ensure that this great work can continue.
I think we have a question in the chat from Andrew. We have nurse-driven protocols that can be used. My question is, how can we get nurses that are hesitant to initiate a nurse-driven protocol to actually use these?
I'll open that up to the group. What solutions have you all found? Gabrielle, do you all have nurse-driven protocols in California or?
Or yes, we do. Well, I mean, a lot of ours are nurse-driven protocols. We have, for example, standardized procedures that are built into our system, which allows nurses to kind of determine the first, you know, we have an umbrellaed order under physician supervision for patients meeting a specified criteria. So I think just really giving the nurses the training, the empowerment, and the tool to do it, and giving them the buy-in on why this is, you know, helping the patient's care, you know, get the delivery of care sooner to the patient, really is a great motivator for most of the nurses. And once we built our first standardized procedures in our hospital, very quickly the nurses were asking for more. So I think it's really in how you, in the application and the promotion and the also education and understanding of the nurses to really accept those protocols, for example.
Yeah, great points. And then how impactful were huddles or those regular education campaign initially with the new protocols, I'm sure, but then as far as maintaining, I guess, thinking about standardized ways to catch all the shifts and those kind of things.
So for myself, for pain improvement, like I said, we did the standardized procedure protocols. We did do some one-to-one feedback. We would also do chart audits. We would do huddle info sessions and just periodically readdress it for consistent delivery of, you know, of the same consistent message. And, you know, we have, like, our hospital's pretty busy, and I'm not sure how many on this call are super busy, but we have initiatives rolling out every week, it feels like. So really, it's just really keeping it to the top, you know, bringing it back up to the top of the list. I think that really is helpful. And that's really where we use the huddles, you know, our staff and shift huddles to really revamp that once a month or once every other cycle, where we update that information. So I feel like bringing that back up again and then sending periodic evidence-based, you know, updates or informations like you have posted in the PEAK toolkit, I think is really, really insightful and helpful for the nurses.
Really great thoughts. Any other systems that have found similar integration tools to help with this? I'd say for the bigger size hospitals as well, adding it to the potentially to the physician shift sign out too. We had an electronic little tracker for our handoffs, and so it'd have a different topic on the bottom each time as your like reminder bullet. So for the to remind the physicians that, hey, there's the standing delegated order. So even though we weren't the ones to directly write some of those orders or those types of things, it would be a reminder that those protocols were in place, and so we could organize and support those as well. So then if somebody was asking for pain medication or those kind of things, we could say, great, happy to help. But you know, there's a standard order that you can go ahead and initiate. Feel free to do that. You know, unless there's a question. So I think that was something that helped us as well. Getting to the, tell us a little bit more about the STAR charter recognition, Gabriel.
Hey, so I've done this with other initiatives in the past as well, and I don't try to overdo it because then it kind of loses its luster. But when you have a really great charting, really good charting audit that you catch, or you catch a consistent STAR charter, like somebody who's really understanding the policy, who's really taking the time to document all the required documentation for proper pain charting, for example, that just maybe once a quarter, acknowledging that person for that you see them, that you see that they're a good example, and that you bring it to their attention. It also helps the management team be aware of who your well-trained staff are, so that when there is someone who may be needing mentorship or remediation or maybe some additional resources, that then becomes a unit resource for the rest of the team. And that's kind of what we try to implement here. We are a very large, like 160 or 70 employee, nurse team here. So across all of our shifts, it's a lot of people to train. So it kind of helps keep them engaged. It keeps them rewarded and moving in that direction, and then being a good example and mentor for the rest of the team as well.
Yeah, I think hugely helpful and a morale builder in a way that's then financially, incentives are tough, and so that's a really great way to do that. If you have a bulletin board in the break room or back hallway or wherever it might be, to try to think about putting that as the pain management star of the week or whatever it might be.
Yeah, we actually email it out to the whole staff sometimes.
Oh,
too,
fantastic.
just for recognition. Yeah. It embarrasses some people, but it's kind of for team awareness of that person, is one of our STAR charters.
Has anybody else used a something similar, or reward system or kudos points? Deborah's just putting in the chat. Tell us a little bit more about that if you can.
Yeah, so I work for Christus Winsboro. We're a small facility. I have about 50 nurses that are direct reports. And what I do is my auditors, which is my quality team, keep a scorecard, and they send that to me every month. And then I post those star documenters, not only in our monthly staff meetings, but I award them kudos points as well. And then those that regularly do it, I do a quarterly drawing for a gift card for some restaurant or something around here. So it really gets them, like, they get competitive on who's going to get that $25 card. So we do an employee of the month parking spot for the one that wins monthly, and it works really well.
Fantastic. Really great ideas. Kirsten, tell us about your Kudos Kids Award.
Yes, so I do monthly chart audits, and I just create like a list of people, and me and then senior management, we just discuss it. And then we choose one out of there, and then we give them a certificate and a pin, and then they get put into a drawing, and then at the end of the year, they just get a gift card or something to that effect.
Fantastic. It's really great. Cassandra is going old school with some stickers that they love. So that's awesome. Added to the star charts for that month. And then raffle. That's great. What other tips or tricks have you all learned or employed to help with those chart audits? I know, you know, that too can be challenging and time consuming. Are there ways you've been able to build that into different job descriptions, or help take that burden off, or you know, clearly seeing the reward is I think exciting and worth the effort, but what other ways have you guys found to help with some of that? Where there's not a magic answer, it just needs to be done and entered.
I'll just say, this is Cassie again. I feel like I've been talking a lot, but the work that you guys have done with NPQRC has been really helpful, because I'm the first PEC that our hospital has had. Because we called them PDLNs in LA County. When our last PDLN left and they had asked me to help with chart audits, I was like, I'm not doing that. I already have 3 floor shifts, you know, I'm not doing that. And so it kind of, and then with all your guys' research and things, it kind of helped push into a role that was like, well, no, we needed someone with dedicated time to do this, because it can be very time consuming. So with like some buy-in from management, it took a while to get it approved, but I was approved almost 2 years ago now to have actually like 2 days of office days, which is like to actually have dedicated time to deal with PEDS education and chart audits, to have this PEC role. So that's been so helpful. I don't know how other people do it when they're doing, you know, their full-time shifts on the floor and have to do the audits, because it is a lot and it can be really time consuming.
Yeah, thank you for your advocacy and for working for that. As we've seen across the country, new PEC roles are about, Kate can correct me, 50% funded or some time for that, and so that can be so crucial, and driving that forward. And there's lots of really great data coming out through EMSC looking at that, and so we can continue to try to help provide that, and then we can reach out and get your stories too, because I think that's really exciting. I know there's a couple other folks on this call, and they may not have the opportunity to speak up depending on what else is going on in their day, but I'd love to see if we could hear from any of the other folks that had done those PRQC projects on pain, because I know we've got a couple of them I can share locally, that we are working to introduce JTIP, the jet lidocaine, and so working on our pain assessment and regarding kind of a modality intervention as well. That took much longer to start than we anticipated. We were hoping to do that within the context of the last PRQC session, but you know, I think continuing to plug away and maybe not happening on my timeline is something that we always learn through these projects. So I'll just share our opportunities. It looks like Kirsten might be working on JTIP as well at Good Sam and Vincennes. I don't know, Kirsten, do you have any tips or tricks with implementation for that?
I reached out to the rep for our area, and I can tell you that like the company does not provide the trial J-tips. You have to purchase them. But I just chose super users, like 5 super users from the different shifts in the emergency department. As well as we have a PIC team that also does ultrasound IVs for us, and she's included in that. But anyone who they think that would benefit, they trial it on that patient. We're using them school-age children and above right now. That way we get good quality data for the trial.
Fantastic, fantastic. And it looks like Amanda's using it in age 1 to 17. Great, because we certainly know that needle phobia heads well into adulthood. And so that's wonderful. And Tara looks like 3 to 10 is her target as well. So wonderful. I think another thing we've learned from a lot of centers that have implemented is like you said, getting those super users and having them work through and getting that experience. So if you have the opportunity to integrate with your child life team or with you know, folks that can really take the time to advocate because there is a little bit of a learning curve, and anything that you do implement almost always does take a little bit extra time and setup, or you know, whatever the framework might be. And so it's really great to see so many folks looking at that. What other pain modalities are you guys thinking about introducing with the advent of being able to document and assess pain in a more consistent fashion? Are you working on other implementation strategies? For topical creams or anything for IV starts or whatever it might be? Ooh, great question about painies. The freeze spray for injections for IVs. Who's using a similar product? Anybody who's using painies wanna comment for Tara? Love these comments. So many using LMX for most ports, and then for IV starts as well. And then Buzzy is still a fan favorite with the vibrating cold Buzzy Bee for starts as well. So really great adjuncts to help improve pain in kids for those access opportunities. Anybody want to verbalize their painies experience?
Hi,
No.
this is Gabrielle again. I feel like I'm talking a lot too, but I'm trying to give others a chance to speak. But we've used painies for a very, very long time. I personally think it's a fantastic product. And I think the concept of it, if it's in conjunction with good explanation by the nurse, both to the family and to the patient, within their ability to understand what you're going to provide, is really like the key to making it a successful application. So, but I definitely recommend it. I've used it myself. It's usually best for, like, I'll say for school age kids. The toddlers don't really understand it too much. I think it scares them a bit more, but like young school age or a little bit older kids who might have needle fear of needles or whatever, it usually works really well. It gives them a little bit of a delayed reaction, and then it dulls the sensation of the needle and reduces the pain. They still feel something, but it's just blunted. So I definitely advocate for the use of it if you don't already have it.
Great, thank you. That's really helpful. Yeah, I think like you said, that the cold at first is a little bit discomforting to that the toddler age if you can't kind of communicate, but yeah, some of them like it or
Yeah, I think it's a fine line. Sometimes it scares them when you first spray it, but if you can also, I've also done where I've done a little tester patch like on the back of their hand before I go in with the needle, and I say, do you want me to use this on your arm? Does it feel cold and icy? And then I'll do like a test tap on top of it with the tip of my finger. And that's how I kind of teach and gauge whether the child's going to have comfort by using this product or not. And so it's kind of really just a nurse gut to kind of give it a try, and then see if if it really startles them and scares them more, then you're just sometimes better off just abandoning that particular modality. But there's ways that you can also enhance that product to really be effective.
yeah, really great points. And as with anything, taking the time to tell and explain and show in a child-friendly, age-appropriate manners goes a huge long way on the whole experience. And so yeah, really great tips and tricks there. And then Buzzy too is usually helpful to let them play with in advance to not just putting it on when you're ready to do that poke or whatever it may be, but letting them play with it a little bit and see. For digital blocks, I really like Budsy as well. I just want to make sure we give Deborah and Jessica or anybody else who had PRQC projects and an opportunity for any lessons learned or thoughts or comments here for a minute, and then we can sort of move on to just our last section here, just talking about updates. Okay, yeah, Gabrielle says, Gabby says Buzzy is great for IM as well. I really do echo that as well, or even for vaccinations in the clinic, those types of things. But great. Well, I will turn it back over to Casey, and we'll talk about those updates, and we'll continue to look for ways to integrate all of this great feedback. If you have report forms or kudos templates, those kind of things, feel free to share them with the team too. We can collect those and make sure that they're available to folks. And really thank you for your opportunity today and for this really rich discussion showing all the incredible work that you all are doing every day. So I just thank you, because that's always an opportunity to learn from you as well.
From me as well, thank you for your participation and a great discussion. While we are all together, I did want to provide some updates from NPRQI today. As you continue to utilize NPRQI, consider ongoing data entry, as this will help you to maximize the benefits of the platform. So this is based on your team's bandwidth and patient volume. The patient chart should be entered at regular intervals based on your sampling method. And then over the course of the PRQC community practice, we will continue to discuss measures found within the core measures. So that's weighing and recording in kilograms, pain assessment, abnormal vital sign reassessment, as well as the suicidality clinical group. But as a reminder, as you continue to enter data, you can view other clinical conditions, including interfacility transfers, seizures, respiratory, vomiting, and head injury.
And then I would say, just when you're looking at that and thinking about entering your data, and even in the things that you all have talked about, is do take a look at, we talked about just, not chatting about patient characteristics specifically, but thinking about shifts or, super users, like you said, super users on different shifts. So think about any variability if there's gaps in those pain scores that might be a target. So thinking about the weekends, night shift, whatever, day shift, whatever it might be, to as far as just looking at your interventions in your data. Sorry, Casey, that just made me think about.
And if you want to discuss your individual data sampling strategy, joining MPRQI office hours is a great opportunity to have that conversation as well. But if you're requiring just technical assistance, data entry issues, problems accessing the dashboards, or needing to reset your password, or if you have challenges resetting your password, you should be able to do that on your own on the webpage. But those other types of problems, please reach out to tap.support@clario.com. And then you'll need to include the information such as your hospital name, your username, user access type, your email, and then the platform, project information, and project code as displayed on the screen here is what you would need to include in your email when reaching out for technical assistance. If your team is changing and you need to update your MPRQI data portal users, please email Beverly Swanson at austin.utexas.edu and include the name, email, and access level of that new individual. And as a reminder, sites are allowed to have 5 data entry users. So if that needs to be changed, you would like to remove somebody and add somebody new, please reach out to Beverly and she can help you with that. And then we have for you the links to the data portal and performance dashboard. Another way, you don't have those links, you can just search for the MPRQI page. It's at the top of their homepage to access both the data portal and the performance dashboard. Great ways to get to that information, and Eleni's been sharing those links in the chat for you. So our next community practice session will be on May 20th from 11 to 12:30 Central. We will be joined by Robin Goodman and Dr. Shayla Yanger to discuss the reassessment of abnormal vital signs. In the meantime, if you do have specific MPRQI questions, please register for an MPRQI office hour session. These are a 20-minute one-on-one session with members of the MPRQI team, myself, to help answer your specific questions. Registration links for April will be shared soon. Additionally, in the coming months, physicians and physicians' assistants will be able to earn MOC Part 4 credit for their engagement with MPRQI. We'll be sharing more information with you all soon regarding that opportunity. That is all we have for today. So today's recording will be posted to the new PRQC Community of Practice webpage, and we look forward to seeing you in May.
And I definitely encourage office hours. I come to office hours, I screw up something with my password or my dashboard I'm not able to see correctly. And it's always just such a great opportunity. It won't take the whole time. They'll get you a window. So I do just really encourage any questions, comments, use those office hours. And we just really thank you for your time and energy to this and for the amazing commitment you're making throughout your systems to impact the care of children. So thank you again.
Thank you all and have a great rest of your day.